Yes, I'm quite. So this is the second ENT session that we've had with this group that's been organised by Sunny and his colleagues in Myanmar. The first one I talked about otology, but on this occasion, my good friend and colleague Dick Ainon Lewis is going to talk about rhinology. Nick and myself have both been part of the ENT UK Global Health Organisation, and Nick is the current chairman. He works as a consultant ENT surgeon in London at St Bartholomew's Hospital, and has an interest in rhinology amongst other things. So I'm sure you'll find what Nick has to say of great interest, because we all know that in general practice, rhinology forms a big proportion of work, certainly in the UK, and I'm pretty sure it does in Myanmar as well. So Nick, thanks very much for taking time out of your schedule to join us. So feel free to start your presentation.
That's right. Thanks very much, Robin, and thank you, Sunny, for inviting me. I have actually been to Myanmar, just briefly for a day, and in northern Myanmar, and it's a very beautiful country. But I did end up in a police station after about 3 hours. But they escorted us round, and it was a wonderful place actually. So I've been asked to talk about rhinology, which is a big subject, and I'll try and make it as relevant to you as GPs in Myanmar. If you have any questions, feel free to ask, and perhaps if Sunny, you could sort of coordinate that. I'm very happy and Robin is also happy to answer questions at the end, but if there's any burning points as we go along, I'm very happy to stop and answer those points. And I hope I sort of get it at the right level, and it's not too simple or too complicated. And I always really think about the functions of the nose. And it's interesting because in the UK, we don't, as ENT surgeons, think that much of the function of the nose, but there's a large group of people who are involved in wellness, who aren't ENT surgeons, that believe that breathing through the nose will lead to many health benefits. And it's somewhat controversial, but we all know that it's important in terms of filtering and warming the air. The nose is like a little air conditioner. And unbelievably, the pattern of airflow and trying to understand that is incredibly complicated. But nonetheless, that we know that nitric oxide is produced from the nose and sinuses, which is otherwise known as the mighty molecule, and that supports respiration. It is in fact tried in some of the COVID trials in the US. A bit of physics, if you remember back to medical school, which is very relevant actually to a lot of things that we do in ENT. And it's really this approximate relationship between flow and the size of the airway. So the airflow is approximately proportional to the fourth power of the radius, if you like. So we spend an awful lot of time, certainly surgically, trying to make a tiny difference, a couple of millimeters here and there, but it impacts on the flow of air in a disproportionate way. And of course, we always think about that with the pediatric airway. Very small difference in the size of the airway makes a big difference in the airflow, which can be critical. The Bernoulli principle is also something that you may remember, and every engineer will know about the Bernoulli principle, because it's why aircraft wings are designed in the way that they are, with the convex side on the top. And it really indicates that when air enters the nose, it very soon enters the narrowest part of the nose called the nasal valve. and that causes an increase in velocity, which generates negative pressure. So we all know when we sniff, the side wall of the nose sort of collapses in. And of course, you can measure that, and you find that in pretty much everybody, they have a bit of that. So that can be really, very important in terms of assessing nasal obstruction. And of course, the sense of airflow, being able to consciously be aware of how much air is going through your nose, is complicated. And we think it's probably thermoreceptors in the nose that pick up changes in airflow. And along with that, there's a lot of psychology. So for some patients, you know, being completely blocked and unable to breathe through their nose doesn't matter too much. You know, they get on with their lives. And for other patients, they can't function, they can't leave the house, they can't socialize, they can't go to work. And so there's a lot going on. There's probably more than you sort of think, really. And it's like most parts of the body, that the physiology and pathology, the more you know, the less you know. So we normally look, I don't think it really matters, but so we'd normally look at the front of the nose, and that's a pudicum speculum there. But you can use an endoscope, or you can use a very fancy endoscope, a videoscope. But most doctors have an oroscope for examining the ears, and you can get a pretty good view of the front and the middle of the nose with an oroscope. Of course, looking with an endoscope very often does show you things that you can't see. And here there's a septal perforation with an adhesion there. And that's a turbinate. So you can always see the inferior turbinate when you look into the nose. And we'll talk about nasal polyps in a minute, but they're very often misdiagnosed as being a polyp. So nasal polyp is not sensate. If you touch it, patient can't feel it. The turbinate tends to be pink and swollen, and it's usually just inside and on the lateral surface of the nose. I don't know how many of you sort of think about the anatomical structure and the rigidity of the side wall of the nose, but you can test that with Cottle's test, which really involves a modified Cottle's, which is putting an instrument inside the nose and asking the patient to breathe in to see if that improves their nasal airway. And so there's a lot of causes of nasal obstruction. We'll look at one or two of those. Of course, rhinitis is a very common cause of nasal obstruction worldwide. And, you know, I have seen it written that it's the second most common disease in the world. And of course, you know, I'd be very interested to see if it's a common thing in Myanmar and how it's managed and how significant it's considered there. You know, we all know patients who have rhinitis, and probably some of you attending this lecture will have rhinitis. I certainly do. You can break it down really into allergic, infective, and non-allergic, non-infective. And so there's lots of things that can affect the nasal lining. We sort of moved actually past one aspect of nasal physiology, which is called the nasal cycle. And that's a very interesting phenomena that occurs in most human beings. And what happens is the resistance is constantly changing from one side of the nose to the other side of the nose. And that is determined by the autonomic nervous system. And usually between 30 minutes and 6 hours, the resistance is changing from one side to the other. And so sometimes the patients, sometimes they're more blocked on one side, and then they're more blocked on the other side. But of course, there's lots of things that affect the nasal lining, and it can be things that we eat or drink, smoke, irritants, pollution, you know, domestic and cosmetic products, emotion. And a lot of these things are really having an effect on the autonomic nervous system. So going on to allergic rhinitis, so very common. And it can be, of course, you know, having a bit of rhinitis or mild rhinitis, well, you know, life's okay, you've probably got other things to worry about. But if you have moderately severe or severe rhinitis, it can be pretty miserable. And we know this from the quality of life questionnaires. And so, you know, you can tell patients come into the surgery. Obviously, we see lots of patients with nasal obstruction, but sometimes patients come in and you can tell they're blocked and it's affecting their voice. And you know, they can have a pretty miserable time. And it's very often associated with asthma. And in basic terms, we're going to have a look at ways of treating it, which is basically avoid the allergen, medication. There is desensitization, which has been around for many, many years and is basically usually carried out by the allergy consultants in a way of modifying your immune system. And there are new drugs coming on board to treat these things. And so we think about, you know, pollen and house dust mite. And I'd be interested to know if house dust mite was an issue. It's such a bizarre phenomena in many ways that human beings should be allergic to some of these things. It's really difficult to really understand in any shape or form. And there's dogs, of course. And you can if you have allergy testing available, which you may or may not have, you can do that either with a skin prick test or blood tests. But obviously the history may well give you an indication about what's the problem. And there's been a link certainly between asthma and allergic rhinitis. There's a sort of, you know, some people have described rhinitis as the asthma of the nose, but I think that's probably going a bit too far, because with asthma, it's really smooth muscle, which is the key. But if you look at the inflammatory process that goes on, there's a lot of common pathways involved in the inflammatory pathways there. And so we're going to use steroid nasal sprays. We're going to avoid the allergen. So, and that's, you know, for things like house dust mite, it's, you know, buying covers for the pillow, mattress and duvet, as most people in the UK don't do. And I suspect that that's probably not, you know, commonly done in Myanmar. But I would assume that you have access to nasal steroids. So we're going to give them steroid nasal spray. We're going to consider antihistamines. And then there's a few other drugs, mast cell stabilizers, anti-leukotrienes. Decongestants, the message about decongestants, as you know, is to only really take them for up to 5 days, because they're very powerful, cause a fantastic vasoconstriction in the nasal lining. And then over the course of time, the nasal lining then starts to dilate. And it's got its own name. It's called rhinitis medicamentosa. And so I saw a patient recently been taking a decongestant every day for 30 years. And of course, without the decongestant, the patient can't get to sleep. And steroid nasal spray. So in terms of topical steroids, steroid nasal sprays are really perfectly safe. They can dry the nose and cause a little bit of bleeding. That's probably the common side effect. But you could probably take a nasal steroid for the rest of your life without having any meaningful side effects. And you know, we prefer the patient not to do that, but systemically it's a very small amount that's absorbed. And then there's steroid drops, which come in different forms, and there's some absorption from steroid drops, certainly betazole drops, which you may have available. So they're more powerful, but we are to some extent guarded in terms of long-term use with steroid drops. And then, of course, there's oral prednisolone. If you have a patient with really severe rhinitis, I normally think in terms of a rhinological dose being 20 milligrams a day for a week. And so it's not a huge dose. It's unlikely to cause side effects. Of course, when you give a larger dose, we get the patient to take it in the morning, cover it with omeprazole or talk about gastritis, and then always ask about all the, diabetes, blood pressure, and so on. I've put quite a bit of information on the slides, partly because then you'll have the slides to refer to if you need to. But I want to keep going and then have a chance for questions at the end. And there are newer corticosteroids which have almost no absorption into the circulation. But the thing with the nasal steroid spray is when you give it to the patient, you need to explain that it will take a few days before it starts to work. And I would normally try it for 1 month as a minimum before you make any judgments on it. And then antihistamines. The thing about antihistamines is that different people respond to different antihistamines in different ways. There's not a hierarchy as such, so that one antihistamine is necessarily better than the other. So I think it's always better to start just with what you have available. Cetirizine is one that we use in the UK quite a bit. And this is a picture of Sterimar, which is a saltwater wash. And there's lots of nasal douching products available. And on the whole, I think we were sort of skeptical when they came in as ENT surgeons 10, 15 years ago, even more, 20 years ago. But I think that there's certainly a role for nasal douching and saltwater washing, whether it washes, pollution or allergy or infection out of the nose. It seems to be helpful. And interestingly enough, it doesn't seem to be detrimental, because the nasal microbiome, which a lot of people talk about the microbiome in the gut, and we don't really talk much about the microbiome in the nose, what's normally in the nose, what's supposed to be in the nose. But it doesn't seem to be detrimental, but I wouldn't say it's a long-term treatment, but certainly in the short term, a saltwater wash can be very effective. And there I've put this other slide with a reference on concerning antihistamines. Some patients, of course, antihistamines do have a sort of reputation, if you like, for potentially causing some tiredness. So, it's worth asking about that. But certainly, depending on the cause of allergic rhinitis, I would say that sometimes antihistamines are completely ineffective and sometimes they're helpful. Certainly if it's a pollen allergy, they're helpful. And again, it's a question of just trying it. If it doesn't seem to help, stop taking them. And certainly for, perennial rhinitis, which is, house dust mite or a rhinitis that goes through the whole year, antihistamines may or may not be helpful. And then a few other things, we mentioned decongestants, which should only be taken for a short period of time. And there's montelukast, which is a drug that can be used in asthma and rhinitis and polyps, and it's an anti-leukotriene. We mentioned decongestants and nasal douching. A quick word about immunotherapy. I'm not sure what the situation is in Myanmar, but there may be a place for this immunotherapy for patients with severe allergic rhinitis. Getting on to CRS, so chronic rhinosinusitis, really, so it's about the nose and the sinuses. And I usually say to patients that the sinuses are spaces in the head, which are lined by mucosa, which also lines the nose. And the nose and sinuses, they're like a little mucus factory. When they're producing up to 2 liters of mucus every day, and it goes down the back and you swallow it without noticing, it's a bit like engine oil. But of course, with rhinitis and with rhinosinusitis, the inflammation can cause to an increase in production of mucus. And there's a heck of a lot of research on rhinitis and rhinosinusitis in Europe, and there's a document on the internet, which is a sort of European position paper on CRS, and it's a great, long, huge document. But I think the conclusion is that with chronic rhinosinusitis, the one thing I would say is we don't know why people get it. I think that's the first thing. And there's a few theories about why you get it. I mean, you know, if there's no polyps, you kind of think, well, the patient had an upper respiratory tract infection at some point, and it just hasn't cleared up because the sinuses have got inflamed. Stagnant mucus always gets colonized by bacteria. That causes swelling, and that prevents drainage of the sinuses, and so on and so on. But the fact of the matter is we don't really know why people get sinusitis. And the other thing is that surgery, it certainly can be effective, and there's certainly a place for surgery, particularly in acute sinusitis. But in chronic rhinosinusitis, it's not, the concept isn't that surgery is a cure for the condition, but it plays a role. And so it's common, and it's certainly an expensive problem in the US, and can cause you know, a fair amount of suffering, I suppose you might say. There are various different classifications, and there's a lot of work done on trying to find different types of inflammation, and this type 2 inflammation where there's high levels of eosinophils and certain cytokines, and that's been linked with nasal polyps, chronic rhinosinusitis with nasal polyps, and with asthma. And so there's a lot of research. I mean, I think it does show how complicated the immune system is in many ways. There's some conditions that are linked with sinusitis, including cystic fibrosis and other conditions, vasculitis. Now, I've put this document in, not really to just go through it all with you, but as a reference, because I think it's quite a good flow chart. It's from ENT UK on how to deal with CRS. And I will keep moving a little bit onto nasal polyps. Again, they're usually coming from the middle meatus, and that's a picture. The swelling in the middle is the middle turbinate, and the sinuses drain into the space which is lateral to the middle turbinate, which is the middle meatus. And very often a polyp will be seen there. And as I say, it doesn't have any nerve supply. We don't really understand why patients get nasal polyps. Sometimes they can be so large that they are extending to the front of the nose. And there's a turbinate, and that's the differential diagnosis. And you can see the difference there. Infective rhinosinusitis, and I'll talk a bit more about the treatment of these things as well. But infective rhinosinusitis, of course, you know, very often starts as a viral infection, and then it's followed by bacterial colonization. But acute sinusitis, it's certainly worth treating that. We generally speaking would treat it with a decongestant and some antibiotics and a saltwater wash, because very occasionally an acute sinusitis can cause complication, and I'm going to talk about complications in a minute. I've had 2 patients in London who've died following acute rhinosinusitis, 2 young people, 2 men, and one with encephalitis and one with a large brain abscess, and which weren't treated. So it's always, although that's not common, it's always worth remembering that. And of course, the question is, in chronic rhinosinusitis, well, viruses aren't usually implicated, but it's probably the case that bacteria are, because you get stagnant mucus that gets infected. Fungal sinusitis comes in different varieties. It can be allergic fungal rhinosinusitis. You've got an allergy to fungal spores, high levels of IgE, and it's a disease where, you know, they really need surgical treatment and they need referral if possible. Then invasive fungal sinusitis, and that's a fungal sinusitis that you see in immunocompromised patients, and that can be rapidly fatal, and it's a form of that that's been seen in COVID. And again, you really need to, you can't just treat it with an antifungal agent. You know, you really need to see an ENT surgeon if you're going to survive, if you get invasive fungal sinusitis. And there's acute sinusitis. And you'll know about these patients that you see, you come with pain and a high temperature, and you may do an X-ray, which is quite good for acute sinusitis, or a CT. And then you're going to give them analgesia, broad spectrum antibiotics, and a decongestant. And if necessary, you might wash out the sinus if they're not getting better, if you're able to do that. And this is a picture of chronic rhinosinusitis from a coronal CT scan. I'm not sure if you can see my arrow, but you know, the sinuses should be full of air, which is black. And you can see the ethmoids between the eyes and the maxillary sinuses, or the antra. And in this case, there's significant disease in the ethmoid sinuses with the pacification. And there's various different options for sinusitis, but it generally, you certainly in children with a large adenoid, you may want to remove the adenoid, which has a biofilm on it very often, which is a sort of community of bacteria, and that's causing all the problems. But basically, functional endoscopic sinus surgery, or FES, is the standard surgical treatment for CRS. I mentioned complications. This is patients who came when I was on call one Monday evening. He'd been diagnosed with severe hay fever. He was pretty unwell, but not horrendously unwell. And you can see, I don't know if you can see the abnormality there. So well done if you've seen the abnormality. And can you see my pointer?
Yes, we can see that.
Okay, fantastic. And I've got a couple of questions there to look at as well. So yeah, so you can see this is an orbital abscess, and it's pushing the eye out there, and it's come from this ethmoidal infection of the sinuses, causing an orbital abscess. And that's something that we see during the winter. We see it quite, it's not uncommon in an ENT department, especially with children. So we have a sort of fairly regular stream of children with infection spreading from the sinus to the orbit. I mean, in his particular case, and I don't know if anybody can anybody spot the other abnormality there? Oh God, I can pick up the chat actually. So, I mean, this is also, it's when you know the abnormality, it's obvious. So this patient, the same patient, he's also got brain abscess there. So he's got bilateral orbital abscesses, in actual fact. He's got bilateral orbital abscesses and a brain abscess. And that's from acute sinusitis. So it's worth just thinking about these things, and we've made incisions here on both sides. In his particular case, we were able to drain the frontal abscess through this incision, but normally you can't do that. But that saved him having a big flap across the forehead. And then we just washed it out there. This is another complication. This is a mucocele. So what happens is that mucus that's not infected, it can become infected. But certainly if you've had a collection of mucus for many years, sometimes it expands and forms its own cavity, causing proptosis and movement of the orbit. Now you can see it there. It's a big mucocele that's been coming on for many years. Again, I've just opened up the patient here. There was a dead piece of bone there that I removed, and we just cleaned it all out, really. There's a dead piece of bone there. Other causes, vasomotor rhinitis, which, you know, you could call intrinsic rhinitis. And I think it's sometimes very difficult to really know what is vasomotor rhinitis. It generally is rhinitis where there's no obvious history of allergy and they've got a very runny nose. And we certainly try a nasal steroid spray. And then there's ipratropium bromide, anticholinergic, which you could try. And there's a new treatment now where you can apply cryotherapy to the nerve at the back of the nose, which reduces secretion in the nose. And that's been used in the US quite a bit. And I'm very happy to answer any further questions as we go along. So deviated septum. So you're going to see quite a few of those, obviously. And nasal and septal deformity. So we're thinking a lot about that. We don't really know, you know, sometimes there's an obvious history of trauma. Sometimes there isn't. It may be related to birth. And then, of course, cleft lip, palate. And I'm not sure if you can see this slide in the corner. Can anybody guess what that might be caused by? And it's quite a tricky. Leprosy, that's leprosy. Yeah. So you see the noses, but we see, I mean, we'll talk a little bit about vasculitis, but that's something else that we see in the UK where they're getting erosion. But there's a septal deviation. Functional septal, right? We're sort of slightly obsessed with that in the UK about the structure of the nose having implications for nasal airflow. And there's lots of different operations you can do there. That's the patient that accidentally had a glass hit by a glass and caused a loss of support. And so we've put a nice, this is what's called a batten graft. So you can put a nice big piece of cartilage here to try and cure that. You can take that from the ear or the nasal septum. Always remember the adenoid. And the problem with this is that you can't see the adenoid when you're looking at the nose from the front. That's the shame. You can do an X-ray. We used to X-ray children quite a bit to see if we could identify a large adenoid. I mean, this is years ago. Robin will remember that, but we don't do that really anymore. But there's trouble with adenoids. So, you know, I mean, if there's any way that you can get hold of a small scope, and I think with time, technology will mean that the tiny little endoscopes will be a lot more available. But that by endoscoping the patient, we get a chance to look at the adenoid. And a large adenoid can cause all manner of problems with nasal obstruction and infection and sinusitis, and certainly in children. The adenoid there. Septal perforation. So we see patients quite a bit, either after, you know, there's a few reasons for that. Sometimes after surgery or cocaine use or other forms of trauma, septal hematoma. So always look for a septal perforation. Choanal atresia, of course, is a medical emergency because the neonate is an obligate nasal breather. So if it's bilateral, you need to stick a big tube through the child's mouth in order to save their life. And then there's a few things. So we do, I don't know if probably nasopharyngeal carcinoma is a pretty rare thing for you. It's a pretty rare thing for us, but we're always thinking about that because if you don't think about these things, you will miss them. And nasal tumors and sinonasal tumors, they're not common, but I do remember seeing a patient in the clinic when I was doing a community clinic, and there was a guy there who was a plumber, and he's quite a stoical guy, and he never really went to the doctor, and he had bleeding from one side of the nose. It was obviously had obstruction and bleeding, and it was sort of getting worse, and he hadn't been referred. And he was a youngish guy, and he turned out to have a tumor. And I referred him to one of my head and neck cancer colleagues, but he died post-operatively. And I always remember that patient, because the thing is about these sinonasal malignancies, they're not common, but you've just got to have one, you know, in the back of your mind, just thinking about could this be a tumor? And that's, of course, what we're thinking about all the time. And there's a list of symptoms that might, you know, raise an eyebrow. There's some tumor there. And there's the interesting thing is that there's a whole load of different types of tumor that can occur in the nose, and they're all different, and they present in different ways. But don't forget them. I put this when to refer, so I mean it very much depends on your circumstances and what referral patterns you have, really. And I put down there loss of sense of smell. Of course, COVID, you know, has affected us all, and I'm sure it's been an important condition in Myanmar, as it has in the UK, and ENT UK have done a lot of work on loss of sense of smell. But we sometimes see patients, obviously, you know, rhinitis, rhinosinusitis and polyps is very common cause of that. But sometimes you can get loss of smell after a severe upper respiratory tract infection, you know, not COVID, or a head injury. Antifungal medication can cause it. It's sometimes worth asking about that. It may be linked to certain neurological conditions. Very, very rarely an olfactory neuroblastoma. With COVID, I'm not sure if you know, anybody's really come up with the miracle cure for the loss of smell. We've tried sort of different things, really, but I think it's worth trying them with a steroid spray. Whether there's this thing really, which is smell physiotherapy, where the patient gets in touch with an organization that sends them different types of smell, and they keep smelling it. But that means certainly there's some evidence to support that. And I've put the ENT UK website reference there, which are constantly updating their advice. So that was a whistle-stop tour through Rhinology, and I hope that something there was helpful. And myself and Robin would be very happy to answer any questions, of course.
Thank you very much, Nick. I hope that was useful for GPs, because I'm sure these are very common diseases that they will see in their everyday practice. There's a few questions in chat.
Yeah, so I can see a bit there. I've got the chat line actually. Rhinitis medicamentosa treatment outline. So this is not an uncommon thing that we see, and so I think step one is to try and work out why they got dependent on the nasal decongestant. So I mean, if they've got a severely deviated septum or a large adenoid, that sort of explains it, and that's going to be the treatment. But other than that, if you think it's just that they've become dependent on it, then you can start them weaning. So you've got to start them on steroid drops or a spray to start off with, and then I tell them if you really need to use it, it's usually to get to sleep. So I say just put it in one nostril. Immediately you start to sort of reduce the dose by half, and they need to be on board, really. I think to some extent some patients just psychologically can't get there, and other patients, when you explain what's going on, they will eventually get off it, but it's really, you've got to give them steroids. Now you could start them off on a course of oral steroids and go down to drops and then down to a spray, and it depends on you know what's going on in the nose. You might want to do allergy tests and so on. I don't know if probably Robin's got some things to add. I'll just go through and then I might refer to Robin if that's all right for some of these points. So do you see much nasopharyngeal tumors in Myanmar? That's from Sunny. So I'm guessing that the answer is not much.
I think we have Professor Mong Chai here. I think this invite him, he's responded.
I think what I would always say about that is that you don't want to miss one nasopharyngeal carcinoma in your career. And the classic thing is we teach everybody is if patient presents with unilateral glue ear in an adult, at least think about a nasopharyngeal tumor, because we know it's much more common in parts of Asia, but certainly in China, Hong Kong, and it's got very interesting sort of carcinogenesis, you know, pathological etiology to it, involving Epstein-Barr virus and diet of dry salted fish, and there's an HLA association, but in certain parts of the world. So it doesn't sound like Myanmar is like, you know, a place where it's a common thing.
But I think we do have quite a large, like in large cities, quite ethnic Chinese population. So I'm sure there would be some cancer there.
Yeah, I think so certainly from our experience visiting Myanmar on quite a few occasions over the last 20 years and working with our ENT colleagues there, there was quite a high incidence of nasal and nasopharyngeal malignancy, particularly as you mentioned in Chinese communities tends to be common. But we also saw quite a lot of other sinus malignancies that we wouldn't normally see in the UK, maybe because they may have been saved up for us to see. But certainly, again, amongst the wards, head and neck cancer in general is fairly common, but there were quite a few nasal and nasopharyngeal carcinomas as well. So I think the thing to emphasize is that, which Professor Mong Kine has put in the chat, is that they usually present late with lymph nodes in the neck and bleeding. And the problem is, well, if you've got a nasal tumor and it presents late like that, the prognosis is really extremely poor indeed. So you're really looking at palliative treatment, really. I think with rhinitis medicamentosa, it's interesting. I'm not practicing anymore, but I took a very hard and you may think cruel line with patients because I told them that they just had to stop it. And I tried substituting it with other things before, but certainly in my recent years of practice, I told patients that they had to stop the nasal decongestants, and unless they stopped it, it wouldn't get any better. But I also warned them that it meant that they would have about 2 weeks of absolute hell in which they wouldn't be able to breathe, they'd be very uncomfortable. But at the end of those 2 weeks, they'd slowly get better. And what I didn't want to do is substitute one medication for another, because quite a lot of them could actually, once they got over the addictive phase, would actually be quite okay. If I did give them anything else in substitution, it was just a saline nasal spray.
Yeah, I mean, I'm glad that we talked about carcinoma, in which case, and the other thing just is whether you see much vasculitis or whether you have much of a cocaine addiction problem in Myanmar.
I wouldn't have thought so. I don't think it's well off enough. I think there's a lot of heroin and
Yeah,
things like
heroin,
that.
right. Yeah.
And now these.
I think one very common condition in Myanmar presenting as an emergency would be epistaxis.
Yes,
So
actually, yes. Yeah.
particularly with high blood pressure, it would be common. So it may be worth just mentioning
Yeah.
how that should be approached in general practice.
I think probably you're right, Robin, because I've got this talk which I sort of do on rhinology, and there's another talk on epistaxis, and yeah, I probably, that was an error. I should have talked about epistaxis. So, I mean, I think of course, epistaxis can be a few dots on the tissue from taking a nasal spray through to, catastrophic bleed from the nose. And so we're always thinking about resuscitation first, if necessary. I think very often bleeds are from Little's area, which is the front of the nasal septum. And there's various ways to treat that. So you've got to make sure the patient isn't sort of picking their nose or irritating it, because very often you get crusting. As soon as the crusting comes off, it bleeds, and then it sort of gets scabby and crusted again. But basically, you can cauterize it with silver nitrate sticks, which I'm not sure if you have in Burma. You may well have those in Burma, in Myanmar, or you can use some form of antibiotic cream, which is also effective. And the other thing you can do is a salt water wash. But of course, when you get more of a bleed that is not being controlled with simple measures, and the simple, of course, that we all know, the simple emergency care is to put pressure on the front of the nose with finger and thumb, and to put the patient's head just slightly forward, so that they're not swallowing the blood. But after that, you may, if you have to deal with it yourself, you're going to use what you have available. Tranexamic acid is available in some parts of the world which you wouldn't expect to find it, which can be very helpful either topically or intravenously. And then you want to put some sort of pressure on the bleed. So you may have access to a nasal pack. You probably have ribbon gauze. So you're going to pack the nose with ribbon gauze plus adrenaline. So you're very often going to have access to adrenaline that you can put onto the pack. And then, of course, you may well have Foley catheters or something like that. Foley catheter can be actually, if you've got a really serious bleed, a Foley catheter really can be quite a useful way of putting pressure on if it's coming from the back, which sometimes you see in the more elderly patient. And certainly you're going to be thinking about whether that patient's taking an anticoagulant or something, that those bleeds can be the biggest, of course. But I think it's a big subject. If anybody has any questions about management of epistaxis, feel free to just ask me and Robin here.
There was a question about
a whole yeah.
It is absolutely.
Yeah.
There was a question at the end about a good book for ENT, and I just put a link to ENT UK website, because they publish a official handbook for medical students and junior doctors, which would be suitable for general practitioners, and that can be downloaded free of charge from the ENT UK website. So I posted the link to that. There we are. It's just come up on. It should be just come up on the chat, so anybody can download that.
Yeah, there's a lot of good guidelines actually. You're right on epistaxis, and if there is any demand at any point, anytime, just let me know. I have got a lecture on epistaxis which I've given before.
Just one question on the how long does it take to recover loss of sense of smell in sort of COVID or post-viral infection? What is your experience?
Yeah, so well, most patients get better in a few weeks or days or weeks, and then there's a sort of cohort, as you would expect, where, I mean, I suppose we'd give it up to 18 months, but there's a cohort where the longer it goes on, the less likely they are that it's going to get better. It's always my feeling. I'm not sure really if there's much you can do about it. I mean, there's lots of trials, vitamin A drops and and all sorts of things, but it's not dissimilar to what happened before COVID with viruses that affected the sensory epithelium.
They're amazing, actually, Lambi. Any more questions? Nick and Robin, thank you very much for your time and for presenting a very interesting talk on common things, most things that GPs see in their everyday practice. That was very useful, and thank you.
Okay, you're welcome.
Yeah, thank you very much for organising it, Sunny.
Thank you, Siamawankai.
Okay, thanks then. Take care.
Yeah.
Bye-bye.
All the best.
Good night, bye.
Thank you.